Morning, this is the CSF author interview with Professor Kevin Winthrop from Portland, Oregon, and we're talking about his paper that he's recently published in Arthritis Research Therapy, the evaluation of pneumococcal and tetanus vaccine responses in patients with RA receiving baricitinib, results from a long-term extension trial sub-study. Morning, Kevin, and welcome to this podcast.
Hi, Peter. Thanks for having me.
Tell us a little bit about the main objective of this study and, this whole issue of vaccination is so topical at the moment.
Sure. You bet. I mean, especially with the new drugs that are coming out, just an effort to understand how they affect vaccine responses is kind of a never-ending line of inquiry given your pipeline in rheumatology. So the point of this was really to look at the JAK inhibitor baricitinib specifically, particularly with regards to two vaccines, pneumococcal vaccine and tetanus, two T-cell dependent vaccines. And there had been some prior work with tofacitinib with the pneumococcal vaccine, although not the T-cell dependent one, but the polysaccharide one, the old Pneumovax. So this was an opportunity really to look at the new Prevnar 13, which is the recommended vaccine in rheumatologic patients nowadays. At least that's one we start with. We then give a booster later with Pneumovax. We can talk about those things later if there's time. But that was the point of the study, and we focused on those two vaccines, again, primarily because A, they're important, and B, we wanted to understand how very affected T-cell dependent vaccination.
Excellent. So can you just quickly tell us, for those who don't have knowledge of it, the difference between PPSV23 and PCV13 and why we need both?
Yeah, so the 23, the old Pneumovax, is a polysaccharide vaccine. Most countries have been using it for years, not all countries. It's fairly weakly immunogenic compared to other protein conjugate vaccines such as the PCV13. So this is a conjugate vaccine, and it only elicits immune responses to 13 serotypes, hence the name PCV13. The Pneumovax is PPSV23, or it's polysaccharide vaccine 23. It elicits immune responses to 23 serotypes. So it covers a broader range of strep. However, it's just not as immunogenic. So what we've taken to doing is, if someone's naive to these vaccines, it's recommended to start with the PCV13, and then later, sometime in the next year, go ahead and boost the pneumococcal responses by giving them the Pneumovax. And what you end up seeing is a much higher titer of antibody responses, at least at the 12 serotypes that are in common between those two vaccines. So that is the current strategy. So they both have value, and they're both shown to be protective against invasive pneumococcal disease and really pneumonia, although that was really very strongly shown with the new conjugate vaccine. So that's how we use them today.
Thanks for that. Just a quick comment. Lenny Calabrese always teaches that if you pneumovax people, they get protection against other coccal organisms. Does that you've got the evidence for that, or is that just a sort of a takeaway comment?
Yeah, I'm not sure exactly what Len was trying to say there. I don't know that you get any immunity beyond the 23 serotypes, for example, that are covered. I don't think you do. I mean, in some cases, studies have shown as those serotypes become less common in populations, there is some replacement of those serotypes causing disease by other serotypes, but not much. I mean, it's very small. In terms of more broad protection against other organisms, a lot of studies you end up doing show that, and it's probably this kind of healthy vaccine user effect that you often see, particularly in population-based studies where you follow a group of patients that has been immunized against something, and it turns out they seem to do better against other things too, and it's probably just the fact that they have better care. So I don't know if that's what he was hinting at or not.
Okay.
But possible.
And the old tetanus toxoid vaccine, just a straightforward one we've been using for years?
Yeah, the tried and true.
Okay. Can you also put one other old wives' tale to bed? that vaccination flares rheumatoid. Is there evidence to support that?
Well, at least not with the current vaccines. I mean, that is something that's always brought out with each new vaccine that comes up, and with lupus and other, rheumatologic conditions. I mean, so far, really none of the vaccines that we have today have been shown to flare inflammatory diseases like RA anyway, or even lupus. The new shingles vaccine is, highly adjuvenated, much more so than any of the other vaccines that we've been using. So I think there is a potential that vaccine could potentially flare autoimmune disease, but that's something that we and others will be looking at in future studies.
Excellent, because Michael Weinblatt was telling me he's done 300 Shingrix without any flares of RA, but we'll wait and see what a proper study shows.
Yeah, I think they're presenting their data in Madrid. I think they've had a couple flares, but I don't think the rate's been, higher than what one would expect necessarily. But we'll see. We'll see their presentation at EULAR.
Excellent. So could you just tell us a bit about the design of this study?
Sure. This was very straightforward. I mean, I'll just tell you up front, it was limited in terms of not having a comparison group. It would have been great to have a group of individuals not on Bari or a group of individuals given a placebo vaccine, something. But this was just a standard open-label study where patients had stable, well-controlled rheumatoid, and they were on Bari either 2 or 4, and most of them were on methotrexate. I don't remember, probably about half were on kind of low-dose steroids. And simply everyone was given these vaccines, both the tetanus toxoid vaccine and the PCV13, and then we measured their immune responses 5 weeks later and 12 weeks later. And, primarily we sought to identify the individuals that had a reasonable response. And I mean, there's no right answer on what fold antibody response implies protection, but we tend to look at, in lots of prior studies, greater than twofold increase in antibody titer at, a certain number of serotypes, or at least half the serotypes. That kind of definition has been used before, and that's the one we use here to define a satisfactory response to pneumococcal vaccination. And then we used a 4-fold increase and then a sensitivity analysis with a 2-fold increase around anti-tetanus concentrations in patients who were given the tetanus vaccine. And again, there's no proven percent of protection with those type of rises, but those are the types of rises that have been used in prior studies.
Excellent. Can you just tell us a little bit about this phagocytic assay for those who don't understand the functional assay, and how it sort of relates to the IgG one?
Yeah, you bet. That was kind of a secondary or exploratory endpoint. I'm really glad we did it. The phagocytic titers, these are really functional antibody titers. So you're measuring not just, the number of increase, but the amount of increase in titers or antibodies that actually are working in opsonizing the antigen. So they are probably a more sensitive measure in individuals, particularly in immunosuppressed individuals. And there's now just a few, but more and more, you'll see more and more vaccine studies use this measure. And I'll get to the results here in a second, but I'll tell you what we found in regards to that, because it was quite interesting.
It is interesting. So let's hear a little bit about the results. And first of all, the baseline demographics, they were pretty straightforward, long-standing RAs, 80% on methotrexate, 30% steroids, but they were biggish, 88 kilos, and their disease was well controlled when they went in. So tell us what the results were.
Yeah, so they were in low disease activity, essentially, and so one might expect they'd have good vaccine responses, and in fact they did. I mean, roughly 2/3 of these individuals or greater had a satisfactory response to the PCV13. Slightly lower responses were noted at the tetanus. I think it was around 40-some%. Had a 4-fold elevation in tetanus titer. If you use the 2-fold cutoff as your definition of satisfactory response, that was higher, in the 60% range. I thought these were pretty reasonable responses. Unfortunately, we weren't able to sort out how methotrexate might be contributing, just simply because most patients were on methotrexate. In the small percentage of patients that weren't on methotrexate, they seem to have the same types of responses. But it is possible that it diminishes. It certainly diminishes responses to the polysaccharide vaccine or Pneumovax. So it may actually do the same thing here, but that remains to be seen.
And is it meaningful that the tetanus response dropped by week 12? Was that not important?
Yeah, I don't think it's probably important. I mean, we tried to make this assessment of, a longer-term response, although, it's just 6 weeks later or 7 weeks later, so I'm not sure how useful that is. I mean, it'd be nice to look 1 year out. That being said, a lot of times titers drop and, it's not meaningful anyway because, it's actually not the titer level that means protection. It's like patients' titers, if they're presented to antigen challenge, they may just do fine and they have enough protection. And actually, that's kind of the rest of our results hints at that. So that phagocytic titer we were talking about was very interesting because what we were able to show is that there was a fairly decent percentage of individuals that lacked a satisfactory rise in their regular titers. However, they did have a positive and robust response with their optional phagocytic titers. So it did seem to identify individuals who didn't really look like they got much protection from the vaccine, but they actually did when we looked at the functional aspects of their antibodies.
Okay, and it looked like background steroids didn't really interfere?
No, I mean, we had enough variability on that variable. We were able to look at both strata, both steroid users and non-users, and we didn't see a difference.
Age?
I don't think we saw much different with age either. And RA disease activity, of course, we couldn't really look at it because everyone was fairly well controlled at the time. But I would suspect that RA disease does, disease activity of higher magnitudes would diminish responses. I think that would be to be expected. Steroids in general low dose steroids in general do not affect really any of the vaccine responses that we can talk about. I mean, the usual ones you guys use in your practice. Higher doses certainly can and will, but low dose, under 10 milligrams, the 5 milligram range and below, you tend not to see much effect on immunogenicity of these vaccines.
And you didn't have enough to distinguish 2 from 4 milligrams of Vari?
No, boy, I wish we did. We just didn't. I mean, we did look where there was a small percentage on the 2 milligram, and we didn't really see anything different, but it wasn't a very large group.
Okay, so that's nice. And what about safety? You didn't really have any issues of any significance?
No, I mean, there was a few local vaccine reactions, but that was it. I can't remember. There might have been a couple SAEs, but they weren't related to the vaccine. So we did have a good experience from a safety standpoint.
And no flares as well. That's good. So what shall we take away from this study?
So a couple things. Number one, I think you can, if you have a patient on baricitinib and they're due for their pneumococcal vaccine, I think you can just go for it. I think they're going to have a decent and robust enough response with Prevnar that you can go ahead and just give it to them. We don't have information on influenza vaccines, so I can't tell you anything there, but I can tell you with tofacitinib, somewhat similar JAK inhibitor, although slightly different, as you know, we didn't see much diminishment of influenza responses at all. So I wouldn't expect to see diminishment with Bari either. So I think you can go ahead and just vaccinate individuals. The tetanus, clinically you're less likely to be giving that vaccine, but people are supposed to get one every booster every 10 years as adults. If you are giving it, I think probably I would just go ahead and give it. I don't know that it's worth necessarily taking them off Bari for a time being to see if you can get a better response. It does bring up the issue around methotrexate. Like I said before, it's very possible methotrexate diminishes the vaccine response. Potentially taking someone off methotrexate might benefit them. I think if I had someone on Bari and methotrexate, well controlled and I wanted to vaccinate them with these vaccines, I would either do nothing or I would think about stopping the methotrexate for 2 to 4 weeks and vaccinating
Okay, so
them. That might benefit them more. Yeah.
Okay. Thanks for that. Now, the big issue with the JAKs, of course, is Zostavax. And how do you manage that Zostavax issue in your clinic? It's always a difficult time when they're flaring and you're about to put them on a JAK to stop things because it's alive attenuated. And the old Zostavax really doesn't seem to be that effective, and we're all waiting for Shingrix, but we can't get supply in Australia. So how do you handle the whole Zostavax issue?
Yeah, we're kind of in that in-between zone. It's a moving target right now. We're still using Zostavax in our clinic for a couple reasons. I mean, primarily we can't get the Shingrix, like you just mentioned. The supply has been hit or miss. I have managed to get it for a few patients, but most patients we can't bring it in. Zostavax does provide protection. It is a decent vaccine for at least a couple years after you give it. So I think it is worth buying some time with it until you can get access to Shingrix. The caveat is, of course, you do have to leave them off a JAK inhibitor for at least 2 weeks after you give it, if not 3 to 4 weeks, and that is true of all biologics as well. Although we did just complete a study showing that even people on TNF blockers while they use Zostavax do not have disseminated zoster from the vaccine, so it actually looks pretty safe, at least in TNF blockers. But JAK inhibitors, I think, are a different story, and if I was going to use it, I would definitely use it before they went on the JAK, and I'd wait 2 to 3 weeks. We did a study a couple of years ago before we put people on TOFA. We vaccinated them, and everyone actually did just fine, and we waited usually about 3 weeks after the vaccination to give TOFA, but there was actually someone who disseminated the vaccine, and it turned out that person had no pre-existing immunity. So I have taken to the following strategy. I ask people if they've had chickenpox. If they say yes, that's actually has a very high positive predictive value of being true. If they're older and they say yes, and I take that. If they don't know, I check their VZV IgG to see if they've been exposed, and if that's positive, then they've had chickenpox. So if they say yes to chickenpox or have evidence of it, that they're a vaccine candidate and they actually have pre-existing immunity. So then I consider the Zostavax, depending on their immunosuppression, and then we'll consider Shingrix later down the line once we have some vaccine and actually some data. So.
Sounds good. So I've had a couple of, or at least one patient who claims that his herpes simplex kept recurring repeatedly on JAKs. Have you had any experience of other viruses? And should we be getting a HPV vaccine for our young females with this kind of medication?
Yeah, those are good questions. Jeff Curtis and I published a study last year, and we showed and we found in a population-based fashion that your gentleman's or your patient's contention is correct. I mean, tofacitinib does increase the risk of HSV, and I would assume Barry does as well, given everything we know. In terms of other viruses, there's really rare CMV. It does happen with both those drugs, but it is quite rare. And then HPV, that's a great question. We haven't seen any sort of signal with HPV-related cancers in the programs from those drugs. Most of the people having taken those drugs are older individuals. I think, as they're starting to be used in younger individuals, the question of how it could affect HPV acquisition or the maintenance after acquiring it is a real good question. It might be harder for your body to get rid of it. I don't know. No one's really looked systematically at this that I'm aware of. So in terms of vaccination, absolutely. I mean, anybody in the age category, and I'd have to look, I think it's 26 and under. But in the U.S., I mean, we're vaccinating women and men in the right age group where it's recommended. I would definitely think that that's important for everyone, and let alone if they're going to go on a JAK inhibitor or not.
And things like Hemovax, Hep A, Hep B, there's plenty of guidelines around, but do you routinely Hemovax people for Haemophilus?
For H flu?
Yeah.
Yeah, I mean, most everyone here has had that vaccination as a child, and so I honestly haven't used it in years. Everybody should be immune, although, I suppose if you're doing, peds rheumatology, that's something you'll encounter. It's a very valuable vaccine in terms of its utility.
Excellent. So, anything else you'd like to comment on this study, and where do you see it going in the future? What other things you're going to work on in the vaccine space?
Sure. I thought it was a nice study. I mean, it was really the first to look at PCV13 of any rheumatologic study, except for the TOFA study that we did in psoriasis, where we also looked at PCV13. So at least we now have two studies, one in RA and one in psoriasis, that attest to the fact that patients seem to have fairly robust responses to that vaccine, which is what we were hoping, given it's a protein conjugated vaccine, and that it should be more immunogenic than the old Pneumovax. So I think that's encouraging. I think where we're going next, well, we got to really evaluate Shingrix, as you brought up. I mean, it's the real moving target in terms of whether we should be using it, how we should be using it, how well is it going to work, and how well it's going to be tolerated. Obviously, the data to date, it's really just been healthy general population over age 50. So we got a lot of work to do to start looking at people with inflammatory diseases and even younger people and people on various immunosuppressives and how they might affect the vaccine response. So I think that's the future.
And you think the opsonization index is the way to go?
Yeah, particularly for pneumococcal responses. Yeah, I think it's particularly in immunosuppressed individuals. I think it's giving you a better understanding of immunity. So I think you'll see more and more of that.
Because you did find that subset where the OI went up even when the IgG titer didn't.
Yeah, and that, like I said, that's reassuring. And that's what we've always thought. We've always thought that, hey, people may not bump their antibody titers that much, but I bet they've improved their protection, and that's what that kind of data would support, that argument.
Okay, well, thank you again for your time, Professor Winthrop. This has been the CSF May Author Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, detailed slide sets are available in the publication section at cytokinesignaling.com, cytokinesignaling.com. Please subscribe to this podcast on iTunes or other podcast media and give us some feedback and let us know what you think. Also, head to the CSF website and enter the CSF poster competition on this month for a chance to win a $1,000 travel bursary for you or a colleague to your next medical scientific congress. The competition ends this week. So visit the CSF website for more details. Thank you very much.